Hello and welcome. Today, we're diving deep into Marfan syndrome, a genetic disorder affecting the body's connective tissue. This seemingly simple tissue plays a crucial role, providing strength and flexibility to structures like bones, ligaments, blood vessels, and heart valves. When Marfan syndrome disrupts this tissue, it can lead to a cascade of health issues. Let's explore this condition, understanding its causes, effects, and available treatments. Marfan syndrome arises from a mutation in the FBN1 gene. This gene is responsible for producing fibrillin-1, a protein essential for forming elastic fibers in connective tissue. The mutated gene leads to the production of abnormal fibrillin-1, weakening the connective tissue throughout the body. In most cases, the mutation is inherited from a parent who has Marfan syndrome. However, approximately 25% of cases occur spontaneously, meaning the mutation appears for the first time in the affected individual with no family history of the condition. The pathophysiology of Marfan syndrome is primarily driven by the compromised integrity of connective tissue. Specifically, the weakened fibrillin-1 protein affects the structural support and elasticity of various tissues. This leads to a variety of problems, most notably in the cardiovascular system. The aorta, the largest artery in the body, is particularly vulnerable. The weakened aortic wall can stretch and bulge, forming an aneurysm. This aneurysm is at risk of dissection, a life-threatening tear in the aortic wall. Similar weakening can affect heart valves, causing leakage or prolapse. In the skeletal system, weakened ligaments and tendons contribute to joint hypermobility and skeletal deformities. The eyes may also be affected due to weakened connective tissue, leading to lens dislocation and other vision problems. Marfan syndrome is relatively rare, affecting approximately 1 in 5,000 people worldwide. It affects individuals of all races, ethnicities, and genders equally. Because it is a genetic condition, it can be present from birth, although the signs and symptoms may not become apparent until later in childhood or even adulthood. The prevalence may be slightly underestimated due to challenges in diagnosis, particularly in individuals with milder symptoms. The signs and symptoms of Marfan syndrome can vary greatly from person to person, even within the same family. Some individuals may have only mild symptoms, while others experience more severe complications. Characteristic features include a tall, slender build with disproportionately long arms, legs, fingers, and toes. This is sometimes referred to as arachnodactyly. Other skeletal features include a curved spine, a scoliosis, a sunken or protruding chest, pectus excavatum or pectus carinatum, and flat feet. Cardiovascular symptoms can include shortness of breath, chest pain, and heart palpitations, indicating aortic enlargement or valve problems. Vision problems like nearsightedness, myopia, lens dislocation, and glaucoma are also common. Unexplained stretch marks, especially without weight change, can also be an indicator. Diagnosing Marfan syndrome can be complex due to the variability of symptoms. A thorough physical examination is essential, looking for characteristic skeletal features, eye abnormalities, and cardiovascular signs. An echocardiogram, a non-invasive ultrasound of the heart, is crucial for assessing the aorta and heart valves. An eye exam, including a slit lamp examination, helps detect lens dislocation and other eye problems. Genetic testing confirms the diagnosis by identifying the FBN1 gene mutation. However, a negative genetic test does not necessarily rule out Marfan syndrome, as some individuals may have mutations in other genes affecting connective tissue. Diagnosis often involves the Ghent nosology, a set of criteria used to assess various clinical findings and determine the likelihood of Marfan syndrome. While there aren't distinct types of Marfan syndrome in the traditional sense, the severity and manifestation of the condition can vary widely. Some individuals may primarily experience skeletal problems, while others face more significant cardiovascular complications. Loeys-Dietz syndrome and vascular Ehlers-Danlos syndrome are related connective tissue disorders with overlapping features to Marfan syndrome, which can sometimes complicate diagnosis. There is no cure for Marfan syndrome, but treatment focuses on managing symptoms and preventing complications. Regular monitoring of the aorta with echocardiograms or CT scans is crucial to detect and manage aortic enlargement. Medications such as beta blockers or ARBs and angiotensin A receptor blockers are often prescribed to slow the rate of aortic dilation and reduce the risk of dissection. Surgery may be necessary to repair or replace a damaged aorta or heart valve. Vision problems are managed with glasses, contact lenses, or surgery depending on the specific issue. Skeletal problems may require bracing, physical therapy, or surgery to correct scoliosis or chest deformities. Lifestyle modifications, such as avoiding strenuous activities and contact sports, are also important. As Marfan syndrome is a genetic condition, there is no way to prevent the genetic mutation from occurring. However, genetic counseling is recommended for individuals with Marfan syndrome who are planning to have children. This allows them to understand the risk of passing the condition on to their offspring and to explore available reproductive options, such as preimplantation genetic diagnosis, (SIP-GD). Careful monitoring and management during pregnancy are essential for women with Marfan syndrome due to the increased risk of aortic complications. The prognosis for individuals with Marfan syndrome has significantly improved in recent decades thanks to advances in diagnosis and treatment. With regular monitoring and appropriate medical management, many individuals with Marfan syndrome can live long and fulfilling lives. However, the risk of aortic dissection remains a significant concern. Ongoing research is focused on identifying new therapies to slow the rate of aortic dilation and prevent complications. This includes exploring the role of various signaling pathways and developing targeted drug therapies. There is also growing interest in personalized medicine approaches, tailoring treatment based on individual genetic profiles and disease manifestations. Research into gene editing techniques offers potential for future therapeutic interventions.